Welcome to the body imaging cases. This is a male 42 years old with right pelvic pain. I have included in this frame all the diagnostic clues for those who would like to take the case as a quiz. They may freeze this frame and have a look at the images and try to find their own diagnosis. MRI of the pelvis has been performed. Here the Transverse STIR MRI shows multiple vertebral body lesions. A large lesion at the right iliac bone. And multiple lesions of the rest of the pelvic bones. And upper parts of the femora. This is a Coronal T1-weighted MRI. It shows the large lesion at the right iliac bone. For the trained eye, this lesion has a rather high signal intensity on T1-weighted images. And because of the multiple lesions in the vertebral bodies, MRI of the spine has been also performed. It shows multiple lesions of the vertebrae. And here again, for the trained eye, the lesion at the vertebral body of L4 shows a rather high signal intensity on T1-weighted images. Diagnosis is A. Multiple myeloma, B. Metastasis, or C. None of the above. The correct answer is multiple myeloma, and the reason is exactly that what we have described, that the lesions have a rather high signal intensity on T1-weighted images. This is because multiple myeloma has a higher content of protein, which is responsible for this high signal intensity on T1-weighted images. But relying on the trained eye is not enough. We need to have a more objective diagnosis, and for this we need to do two things. First, measurement, and second, a standard against which this measurement is evaluated. The spinal cord provides this standard reference. Lesions with signal intensity higher than the spinal cord on T1-weighted images are most of the time multiple myelomas and not metastases. And why most of the time? Self-evidently, because no sign is 100% accurate, but also because we already know certain types of metastases which have inherently high signal intensity on T1-weighted images, such as hepatocellular carcinoma, just to name one example, because of its content of hepatocytes. This sign is quite valid on the usual T1-weighted images, but it becomes even more obvious on fat-saturated T1-weighted images. Why? Mainly because the dynamic range of the image is more favorable now that we have suppressed the very high signal intensity of fat. Now it is clear that the lesion is higher in signal intensity than the spinal cord on the fat-saturated T1-weighted images. Do we need to measure all the time? Preferably, yes, for many reasons. First, because if the lesion is not on the same section as that of the spinal cord, like these 3 lesions of the same case, visual comparison may not be easy. Second, because we need to avoid the visual illusions created by the lesion's surroundings. Here is a diagrammatic representation of the cord and the lesion. You may feel that the lesion is hypo-intense in relation to the cord, while in fact it has exactly the same signal intensity, in this case the same grayscale. When the lesion is adjacent to the spinal cord, as in this lesion of the thoracic spine of the same case, visual assessment would of course be easier and more accurate. On this FDG PET-CT, we notice that there is very low uptake of the FDG by the lesions. We can hardly appreciate the vertebral body lesions, and even the very large lesion of the right iliac bone shows very low uptake, as pointed to by the red arrow. However, we see a lesion with more intense uptake at one of the left ribs, pointed to by the green arrow. Considering that we are having different lesions now, are we back then to the assumption of coexisting metastases, or this is just a rib fracture? This is the typical appearance of rib fracture on CT. Yes, it could be a pathological fracture, but the high uptake is due to the fracture and not the underlying lesion. Otherwise, it is difficult to explain why it is having more uptake than the rest of the lesions. Actually, the presence of this high uptake in the fracture, higher than the rest of the lesions, provides an internal standard that the low uptake in the other lesions is real and is not technical. This fracture is at the 7th rib, the 8th rib, or the 9th rib. And the correct answer is the 7th rib. Let us see how can we get this answer from a single section. This is the lower end of the sternum, and the vertically oriented costal cartilage adjacent to the lower end of the sternum is the 7th costal cartilage. Next to it are the 6th, then the 5th costal cartilages. Having finished with the costal cartilages, we start to count the bony ribs in the opposite direction, and from the same number we stopped at. So after 7, 6, 5, we start to count 5, 6, 7. The fractured rib is the 7th on the left. The classical starting point for counting the ribs is the first rib or the last. However, the 7th costal cartilage is also a very reliable reference point for counting. This is a 3-dimensional volume rendered image of the bony thoracic cage. The pits of the sternum and ribs are the multiple myeloma lesions. They are too small to be seen on the sectional images, so they are better seen on this three-dimensional volume rendered image. Here it confirms that the rib fracture is at the 7th rib. Was it fine to perform contrast-enhanced CT in this patient? The classical old textbook knowledge was that the iodinated contrast agent may precipitate Bence-Jones proteins and damage the kidneys. Nowadays, there are debates and discussions, but multiple myeloma remains a risk factor for contrast-induced nephropathy, and contrast-enhanced CT should be avoided, particularly that MRI can provide ample diagnostic data, as we have seen in this case. The diagnosis is multiple myeloma. Learning points. Multiple myeloma lesions have a relatively high signal intensity on T1-weighted MRI due to their protein content. When the spinal cord is used as a reference, multiple myeloma can be diagnosed when the signal intensity of the lesions is equal to or higher than that of the spinal cord. Metastases, on the other hand, tend to have lower signal intensity than the spinal cord on T1-weighted images, with few exceptions. Multiple myeloma may have a relatively low uptake of FDG on PET-CT. Rib counting can be done from the 7th costochondral junction. This may provide an alternative to counting from the first rib or the last rib in some cases. Iodinated contrast agents would better be avoided in multiple myeloma patients to avoid contrast-induced nephropathy.